And now to continue the conversation, I'd like to call on those who are decoding data and utilizing technology to find new ways to curb the opioid epidemic. Are their efforts successful, and how are they impacting patients? Please join me in welcoming our terrific panel of experts. John Rother, President and CEO of the National Coalition on Healthcare. Dr. Naseema Ait Daoud, Associate Professor of Psychiatry and Neurobehavioral Sciences with the UVA Health System, and David Myers, Chief Medical Officer at the Agency for Healthcare Research and Quality. My colleague Rachel Rubine, healthcare reporter at The Hill, is back to lead this discussion. Rachel, over to you.
Thank you to our panelists for being here. Want to dive right in. Wanted to hear from you, Dr. Myers, a little bit. Your agency is tracking opioid hospitalizations, emergency department visits. Can you tell us how data plays a role, and also just what you're identifying within the data?
Sure. Thank you so much, Rachel, and to everybody for being here today. As we said, I'm at the Agency for Healthcare Research and Quality, one of the smallest parts of HHS, but we're really all putting our shoulder to the wheel to help address in a comprehensive way the opioid crisis. Our agency, small, but doing, I think, yeoman's work in research and how health systems work, in helping health systems improve the quality of care they deliver, and also in providing the nation data about how things are changing. And it's actually that you're asking about. Our national data from the Hospital Cost and Utilization Program shows that this crisis is not the same across the country. When we look at hospitalizations, and if I asked you to think about who's getting in trouble with opioids, many of us think about young men in cities. And as we've already talked about today, this clearly is not the case. It's happening everywhere in the country. But probably one of the most startling facts is in most states in America, the person most likely to be hospitalized due to opioids, or even to go to the emergency room due to trouble with opioids, is a woman. It also used to be a problem of the very young. And while that is still true, younger adults 25 to 35 may be at the highest risk. We're seeing an amazing increase in the number of seniors, people over the age of 65, who are getting into problems with opioids and other medications, that combination with their changes in health and aging. Those kind of statistics, those kind of data, when given to state policymakers, and more importantly, even to local policymakers, that help them make decisions about what's happening in their communities, who are the people, the different ages, the different genders, that allows them to create a solution to what they're facing. And together, it'll be many local solutions, I think, that'll address this problem.
And Dr. Ait Daoud, could you tell us a little bit about what technologies you found to be effective in addressing the opioid crisis, and if there are any that you found haven't really been so effective?
Thank you. Thank you for having us here today, and thank you all for being here. The good news with opioid addiction is that we have FDA-approved medication that work really well. And data has shown that when people are in treatment for opioid addiction with one of the drugs that's available, they do quite well. Some of the challenges, and I see that a lot when I work at the University of Virginia, is lack of access, is that there aren't a lot of providers who are trained and who are willing to see people with opioid addiction. And some of the challenges is that when we a lot of times think that opioid addiction is just someone taking pills and becoming addicted. There are a lot of more problems. There is a lot of times chemical coping. That's what happens. That's why they get into using opioid, is to cope with other things. So you take away the opioid and they're left with depression and anxiety and happiness. And so physicians really struggle in helping those patients. And what we've seen in Virginia is that although we encourage and we provide incentive for training physicians to treat opioid addiction, very few of them actually end up treating these patients.
Are there any technologies, prescription drug monitoring programs, e-prescribing, anything else you've seen on the ground that's working, been helpful, do you think?
So yes, when we talk about opioid addiction, there is opioid addiction, there is dealing with people with addiction, but also part of the prevention aspect of it and education of physicians. So PMP has been a really wonderful tool. I remember being part of the committee that was discussing PMP, and I saw a lot of physicians resisting PMP because it does take a lot of time. You know, you go on the website, you log in, you a lot of time forget your password and have to look for it, then you log in, you put the patient name, you know, the date of birth, a lot of information, and then it pops up. You sometimes have 20 minutes to see a patient, and having to do that takes away from your time with patients. So now we're allowed to have somebody else check the PMP like a nurse before we see the patient. But what we've done at UVA that I found to be extremely helpful is that PMP is now embedded with electronic medical records. So when I pull the medical records to check anything, PMP is there. It's a click away, and I'm able to look, and I feel that it really has helped being there, treating people with addiction, working with physicians who are doing pain management. It really reduces the number of inappropriate prescription.
Mm-hmm. Mm-hmm. And John, sort of from the consumer's perspective here, do you feel like PDMP should have a national kind of standard? Right now, each state has their own. It's more siloed. You can't, always just get data from other states. What do you think?
Good morning, everyone, and I applaud the timing of this event particularly. Yes, we do need a national policy on electronic prescribing. I thought we had tried to address this when the Medicare drug benefit was enacted. Incentives that were contained in that have proved inadequate. We really need to mandate now electronic prescribing. And it's not just because of opioids, it's because the more we learn about good health care, the more we know that physicians need to understand the whole picture. And oftentimes, they get an incomplete picture today because they don't have the whole record. So this is about good health care as well as saving lives. So it's time now to move our entire system in the direction of mandatory electronic prescribing.
Dr. Ajad, can we get your thoughts a little bit about electronic prescribing here and mandating it?
Yeah. I want to follow up on something that you said, something that we do at Virginia that I've had physicians complain about it, but I feel that it actually is a really good thing, is that on a monthly basis, we get a report card from Virginia PMP that tells us how our prescription compared to other physicians, all physicians in Virginia. And it really tells you how many prescriptions you're giving and your level of, or your dose of opioid that you're prescribing. And it really compares you, and it seems to really have an effect on physicians when you get your report card and you're like, wow, I have more prescription than anybody else, and I'm prescribing much higher. It seems to be really making physicians think a little bit more about their prescription. And I think that e-prescribing is going to be the next step that I think should be mandatory. We do that for all other prescriptions, and it works really well. The pharmacy is able to really monitor where things are. Scheduled drugs are the only one that are not e-prescribed at this point. So I think the natural next step is to do e-prescription for opioid. I think it'll make monitoring and it'll make reports so much easier.
Dr. Myers, can you tell us a little bit about electronic clinical decision support tools and if those are being used to help combat the opioid epidemic?
Sure, I'd love to. And John, I agree that as we look, and Rachel, as we think about the opioid epidemic, if we create solutions that only work to help the opioid epidemic, that'll be okay, because this is a real problem. But what we need to be doing is thinking about solutions that will prepare us for the next problem and the one after that. And so things like what we heard is being done at Virginia, of making the electronic health record work better for clinicians, for healthcare professionals, so they like doing their job as opposed to dread doing their job, making the PDMP part of the EHR, that's a win for opioids. That's a win for dual prescribing of benzodiazepines and opioids, which both may have a good reason, but when put together are a deadly cocktail. And helping clinicians see that is a win. Another area is clinical decision support. How can we bring in evidence about what works? Helping doctors and nurses know the right thing at the right time for the right patient into the electronic health record in that same environment. And so at ARC, we've turned our work in clinical decision support, electronic clinical decision support, turning evidence into information for patients and for healthcare professionals at the time of care. And we're doing that. We've been thinking about that issue and working on a larger issue. Now we've targeted it for opioids. We're taking the CDC's evidence-based guidelines for safe opioid prescribing and making those into tools that fire right when the doctor or the nurse needs them. That's a win right now for the opioids crisis. But as healthcare systems like the University of Virginia or UVA can implement that easily, then we'll take things for women's health, things for mental health, things for heart health can all use that same system. That way we all win. And I don't know what the next healthcare crisis will be, but we need to use this one to help us prepare for that.
Dr. Adad, what do you think about those tools? Are those being used on the ground where you're working?
We do have tools like that. Clinicians found them extremely helpful. We call them hard stops. So if I'm about to prescribe something, and I put it, that's why e-prescribing is such a wonderful tool. If I go and put my order, before I sign it, I get a note that says, did you know that the patient is already on taking a high dose of this? Did you know that the dose you're prescribing is much higher than what's recommended? I still can use clinical judgment and say, yes, I know, and I'm still going to do it. But it really helps clinicians and guide them into the best guidelines for treatment. I think it's really, we still at UVA, I mean, we do have some hard stops like that, and I think we're learning. With the opioid epidemic, it has been a learning thing. Every day we learn new things, so every day we're making it better.
If I could add on this, I think to reinforce the point that now I think we've all made, this is not just about opioids. This is a much broader set of issues that has to include mental health needs and services. It needs to, this takes me back to the good old days when alcohol abuse was the main issue we were dealing with for people with depression. We need to really get a better picture of the whole person in order to be able to get appropriate treatment. So it's not just about opioids. It's really about how do we understand the full range of needs and behaviors that leads the patient to put themselves at risk. And from all of the evidence that we've heard already today, people are at serious risk. This is not just somebody who picks up a pill and takes without much prior behavior. This is a repeated situation where people are putting themselves at risk, and therefore it gives us the opportunity to intervene if we know about it in time.
Just sort of building off that, John, would love your thoughts. What do you want to see from Congress that could help? I mean, right now, the House is on track to pass about 50 bills to address the opioid epidemic. What do you think about that effort? And do you think there needs to be more? You sort of mentioned the whole person. You mentioned wrapping in mental health services, et cetera.
Well, I guess anything is better than nothing. But what I'm seeing is a set of incremental steps, which are probably helpful. But as I already mentioned this morning, we're going to need more resources. And, I think more information, better analysis so that we can be more targeted in these kinds of interventions. So that requires real-time information, which leads us back to electronic medical records and electronic prescribing.
Dr. Myers, I'd sort of love your thoughts on this.
Oh, I work for the federal government. I'm not going to go towards Congress. That said, I have reviewed many of the bills, and many of the technical fixes are, I think the congressman was correct. They're laser-focused solutions that will help. I think what ARC's focus is on helping the healthcare system and how we can be a player. Clearly, this is not only a healthcare issue. It is a larger social issue. Right. There are justice issues. But the healthcare system certainly helped us get to this place, and has to be part of the solution moving forward. And so what we're hearing is that there are many folks out there doing amazing work to transform and to partner with their communities. And what we'd like to see are two things. One, that those solutions, like we heard about in West Virginia, become things that are easier for other people to use. So that's ARC's role, understanding what works and helping other healthcare systems have access to that so that they grow. And two, people are coming to us with questions, things that we already know we don't have answers to. So getting the evidence out there about what works, what Congress can do right now, that's good. But we need to know what the problems will be 3 years or 5 years from now, look forward. And that's the role of research, to think about the future and answer those, or start answering those questions now, so that when we need them, we have them. So one of the things that I hope doesn't get lost as we think about this crisis is invest, as we're addressing it, invest in the research to evaluate what's working and spread that, and answer new questions. One of my favorites is, what is the role of mobile technology in expanding access to care? In many rural areas, it's hard to find a trained counselor to help somebody with an addiction, whatever their addiction is. Is it possible to use mobile apps with AI behind them and real people behind them to connect people to services? Is it possible to train rural providers to give them connections to healthcare providers in bigger academic centers like UVA to be their mentors so that they have immediate access when they've got a problem, can get a solution and treat somebody right then, rather than trying to set up an appointment for that person 2 weeks later, 300 miles away. So there's research, new tools we can develop that I think should be part of our broader solution.
And you mentioned rural access, which is a big issue. Dr. Dowd, can you talk a little bit about if there's anything you guys have done in this or what you think could work?
Virginia has funded what David is talking about is a model called ECHO model. And what it does, it's a collaborative model of medical education and healthcare. So before, being an addiction specialist, trying to help rural area, they put me behind a screen and they bring patient and I treat them in different rural areas. It works, but there is a big limiting factor, which is there is only one provider and I can see so many patients a day. So with this model, which Virginia now has funded 3 institutions to really work on it, is that there is an expert in each of the 3 institutions. UVA is one of them, and it's called the hub. And then there are multiple spokes. So instead of putting a patient in front of the screen for me to talk to, you put providers. And those providers, every time I see them on a weekly basis, I'll provide education about opioid addiction. They get CME, they get training, they get support, and they bring their cases. So instead of me seeing the patient, it's clinicians who bring cases and discuss the cases, and it's clinician learning from each other's experience and questions, and the expert is there to help them. So that model has worked really well for different diseases, including hepatitis C and HIV. So in Virginia, now we're adopting it for the opioid epidemic, and we're really excited that we're going to be part of that program.
I just came back from 4 days in West Virginia, and I have to remind us that we live in a bubble here in Washington that's very different than the situation in places like West Virginia, where for much of the state there's no cell service. For much of the state, there's no real functioning healthcare access in terms of hospitalization. And the people who are going to be involved in this are not necessarily physicians, but they're first responders. They're fire, police, nurses. So the training needs to be much broader, and it needs to focus, particularly in rural areas, on the physician extender, non-physician group of people who may be, in fact, the only ones who can be there on a timely basis. So I think we have to really think about the problems in rural healthcare, particularly in the areas that seem to be the most hard hit with opioids, as part of the challenge that we've got to deal with. So it's great to have the kind of resources that Charlottesville has, but that's not going to be the case in many areas that are very hard hit.
So John, I think we just came up with a research grant for you. So Congress should fund ARC to help study how we use the ECHO model to support
There you go.
not just physicians and nurse practitioners, but first responders. So you all heard it here first. John gets credit. Great idea. That model, by the way, Project ECHO, was funded originally by ARC, and it was its research on hepatitis C in the Southwest, showing that primary care clinicians in rural areas who were not specialists could deliver care equal or better, their outcomes, lives
Interesting.
saved, similar to what was happening in the academic center in the state, at much less cost for the patients and their families. And so seeing this model spread is wonderful. And the question ARC is asking, how more can it be done?
Right.
What else do we need to know about it? So it's a great idea.
We're going to open it up to audience Q&A. Does anybody have a question here? Right there in the back.
My name is Nam Nguyen. I'm a cancer physician. I would like to ask a question. What do you think about the role of telemedicine in solving the issue? Because for cancer patients, transportation is an issue. We have patients coming from rural area or in the city, they couldn't get, even though they have insurance, they could not get into our clinic. So, as you say, in West Virginia, in the rural area, I doubt that you can find specialists who have pain experience in treating patients. So what do you think about role of telemedicine?
The more we learn, the more it's obvious that non-medical services such as transportation are equally vital to good outcomes. And hopefully we are moving in the direction of more integrated forms of care delivery that can include transportation services along with the more traditional medical care.
I think there are a lot of issues in telemedicine. It's the perfect case for this. The technology is there. We know how to do it. It's now figuring out how to make it work. Who does it work well for? How do you connect the specialists? But we do also have to recognize we don't have enough highly trained addiction medicine specialists for this country right now. So that's why I think our idea of Project ECHO of telementoring combined with teletreatment for the most complex cases, for pregnant women with multiple substance use who need immediate care right now. That might be the place you want teletreatment. So you get the specialist from UVA working with the woman in rural Virginia. So absolutely, but how to do it? Who to do it for? Is it for just the medication or is it for the social supports? We should be doing telecounseling as well as telemedicine. Lots of great questions, lots of great opportunities to move that field forward.
One important thing about addiction that we have to keep in mind, addiction treatment, is it's really key to decentralized treatment. And that my opinion is instead of bringing everybody into the big institution, is that developing resources in the community. And Project ECHO is one of them. Telemedicine or telehealth is also another option. It's really key that care is being provided by people who live in the community. It's more culturally sensitive. People seem to respond better. When I call from UVA and I connect with somebody in Southwest Virginia, there is a distance separation. I don't really understand what goes on in Southwest Virginia as much as a provider who is in Southwest Virginia who is working with the person. So we have to keep that in mind, and that's why I think a combination of that is providing support and consultation and all that to a provider who is there also is really key to treating addiction.
We're about out of time, but thank you so much, and thank you everyone for being here as well.
Thank you.